I'm Dr. Sarah Hurvitz, Professor of Medicine and Head of the Breast Cancer Clinical Trials Program at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. It's amazing to see how the field has evolved in the past 10 years or so for the treatment of HER2 positive early stage disease. We went from having only one HER2 targeted therapy, trastuzumab, to use for patients with stage 1 to 3 breast cancer in combination with chemo. And now we have a number of HER2 targeted therapies that we use routinely in the standard of care treatment of early stage disease, including not only trastuzumab, but pertuzumab, TDM1 or trastuzumab emtansine, and neratinib. And so the question becomes, how can we most safely deliver treatment to patients, minimizing the toxicity that they may experience and maximizing the efficacy? And one of the questions is, what form of chemo should we use for patients with HER2 positive early stage disease? In the early trials, the large randomized trials in the adjuvant setting, anthracycline-based therapy was the standard treatment evaluated in combination with taxane and trastuzumab. And while a very effective form of chemotherapy, it does have life-threatening complications associated with it, including cardiomyopathy, myelodysplasia, and leukemia. And if you add up all of those risks, it's on the order of 3 to 4%, which is not insignificant in the curative setting when we consider that some patients may be cured by surgery alone. So the use of non-anthracycline-based regimens was explored first in the BCIRG-006 study, in which a non-anthracycline docetaxel carboplatin plus trastuzumab was compared to an anthracycline ACT without trastuzumab, and the other arm compared to ACT was ACT plus trastuzumab. And both of the trastuzumab arms, ACTH and TCH, were significantly associated with better disease-free and overall survival compared to the non-trastuzumab-based therapy. But the safety profile for TCH was superior. And although it wasn't a non-inferiority design aimed to look at whether anthracyclines could be eliminated, the DFS and overall survival associated with the non-anthracycline-based regimen looks strikingly similar to that of anthracycline. Since that time, we've seen a number of other studies. More recently, the TRAIN study in the neoadjuvant setting reported out event-free survival data indicating that the non-anthracycline taxane, platinum, trastuzumab, pertuzumab treatment is associated with very similar pathologic complete response rates, as well as event-free survival compared to an anthracycline-based regimen. So all of these studies that have been done, including another study from China presented at ASCO this past year, indicate that the anthracyclines don't appear to be adding much. And in the era where we have all of these HER2 targeted therapies available for patients, the question becomes, what are we adding to patients other than toxicity? Now, many of our patients are being treated in the neoadjuvant setting prior to surgery, so we can follow their response to therapy. And of course, if you start a non-anthracycline-based regimen and the patient's disease progresses, one has the opportunity to switch to an anthracycline-based regimen. So there may be some patients who would benefit, but for the whole, I would not recommend the use of anthracyclines for early stage disease.